Hello and welcome to the third section of Chapter 13 entitled Respirations. As always, this is Keith Woodmeyer with Wayne County EMS. We're going to get started today on the assessment of ventilation. B is for breathing. When we talk about our ABCs, we do B for breathing. When we talk about breathing here, we're actually utilizing the term ventilation. That's the term I want you to utilize. Normal ventilation is the mechanical process of moving air into and out of the lungs. It is quiet and painless and occurs at a regular rate. Both sides of the chest rise and fall equally. Normal breathing does not require excessive use of the muscles between the ribs, above the collarbones, or in the abdomen during inhalation or exhalation. When we're listening for breath sounds, we'll listen at the top of the lungs in the midclavicular line on both sides of the chest. We listen at the bases of the lungs, which is the bottom, and in the mid-axillary line on both sides of the chest. Make sure it's important to compare each side when assessing our breath sounds. During breath sounds, we're going to determine if breath sounds are present, diminished, or absent. Present meaning they're there, they sound just fine, just normal. Diminished means that they're there, but you can't hear them as well as you really should. Or absent, which means you cannot hear them at all. Then we're going to define whether they are equal or unequal. If breath sounds sound okay on one side, but maybe they sound just fine on the right, but they're diminished on the left, then that would make them unequal. Then we're going to figure out if they are clear, muffled, or noisy. Clear is what we want to hear, just normal inhalation and exhalation. Muffled or noisy is not really what we want to hear. Muffled, just imagine what a muffled sound sounds like, and any noises, you shouldn't hear any noises when you're listening to your lungs. And of course, as I said, we're going to compare them bilaterally. Normal breath sounds are clear and equal on both sides of the chest. Diminished or absent lung sounds may be caused by spasms of the bronchioles, a foreign body, pneumonia, a completely or partially collapsed lung, known as a pneumothorax, or blood in the pleural space, known as a hemothorax. A hemothorax can produce muffled breath sounds which appear distant. Trauma, infection, pneumothorax, and hemothorax are examples of conditions that can produce unequal breath sounds. Trauma, infection, pneumothorax, and hemothorax are examples of conditions that can produce unequal breath sounds. Like we said, you really need to pay attention. This is where knowing the mechanism of injury or the nature of illness plays a large role. Abnormal breath sounds may include crackles, rhonchi, and wheezes. Crackles are also known as rales, indicate the presence of fluid in the alveoli or larger airways. Crackles can be heard in patients with CHF, pulmonary edema, occasional pneumonia, or trauma. They sound like hair rolled between the thumb or forefinger close to one's ear. Rhonchi are sounds produced when air flows through passageways narrowed by mucus or fluid. The sounds like rattling or rumbling in the lungs. Rhonchi can be heard in patients with pneumonia, upper respiratory infection, COPD. Wheezes are high or low-pitched whistling sounds caused by the movement of air through narrowed airways that are partially blocked with fluid or mucus. An absence of wheezing in the asthmatic patient with breathing difficulty suggests that airflow is so diminished, the patient's moving so little bit of air, that wheezing is not produced. The best way I can tell you for differentiating crackles versus rhonchi, this is what works for me, is imagine if you have a straw in a glass of water and you start blowing bubbles. Those sounds is what crackles sounds like, or rales. Now, as disgusting as this sounds, imagine if you were just blowing bubbles in a bowl of snot or just something of the same consistency. And that's what rhonchi sounds like. I know, it's great analogy. Possible causes of wheezing include anaphylaxis, asthma, bronchiolitis, bronchospasms, chronic bronchitis, croup, emphysema, foreign body obstruction, heart failure, inhalation injury, pulmonary edema, pneumonia, and tumors. Now, we need to find out if the ventilation is adequate. In responsive patient, if your patient is awake but appears to have trouble breathing, ask, can you speak, or are you choking? If they are able to speak or make noise, air is moving past the vocal cords. In an unresponsive patient, open the airway, place your ear close to the patient's mouth and nose, look, listen, and feel for breathing. We're going to look for chest rise and fall, listen for the sound of air moving in and out of the mouth, and we're going to feel for breath coming in and out of the mouth. Signs of adequate ventilation include breaths at a regular rate with normal limits for the age, has an equal rise and fall of the chest with each breath, has an adequate tidal volume, speaks in full sentences without pausing to catch his breath. Breath sounds are clear on both sides of the chest. Signs of inadequate ventilation: anxious appearance, concentration on breathing is apparent, confusion or restlessness. Patients unable to speak in complete sentences. You may note the term 1 to 2 word dyspnea, which means it takes them 1 to 2 words to before they need a breath. That's not normal. Abnormal work of breathing. You may note retractions, which is just imagine somebody every time they take a breath, you see part of their chest go in a concave motion. Nasal flaring, accessory muscle usage, sweating, tripod position, flared nostrils, or pursed lips. Abnormal breathing sounds include stridor, wheezing, crackles, silent chest, or unequal breathing. Depth of breathing is unusually deep or unusually shallow. A breathing rate that is too fast or slow for the patient's age. An irregular breathing pattern. Inadequate chest wall movement or damage due to trauma from pain or breathing. Sorry, I think my slide just got doubled there for some reason. Oh, I just didn't went all the way through. Sorry about that. I was going off my notes. A patient who's having difficulty breathing is working hard to breathe. This may be termed labored breathing. They may be gasping for air. You may see their muscles, them use the muscles in their neck to assist with inhalation. That's the sternocleidomastoid muscles. They may use abdominal muscles and the muscles between their ribs to assist them, the abdominal muscles and the intercostal muscles. You may see retractions or sinking in of the tissue between and around the ribs or above the collarbones. A patient who is having difficulty breathing often naturally assumes a position to improve breathing. For example, the patient may instinctively avoid lying down if they feel that they're suffocating or it's harder to breathe when they do so. If the increase in difficulty of breathing occurs slowly over a period of days or weeks, the patient may increase the number of pillows they use at night in order to breathe more easily. As breathing becomes more difficult, a patient may prefer to sit and sleep in a chair such as a recliner. When breathing, in breathing is particularly difficult, the patient may prefer to sit up and lean forward, with the weight of their upper body supported by their hands on their thighs or knees. This is referred to as the tripod position. Patient's chin may be thrusted forward with their mouth open. The tripod position allows the patient to draw in more air and better expand the lungs than if they were lying down or leaning back in a sitting position. Noisy breathing is usually abnormal breathing and a sign of that the patient is in distress. Stridor is a sound usually heard during inhalation that suggests the upper airway is partially obstructed. Stridor sounds like a bark of a seal. The sound of snoring suggests the upper airway is partially obstructed by the tongue. Gurgling is a wet sound that suggests that the fluid is collecting in the patient's upper airway. Immediate suction may be needed. Wheezing is whistling sound that usually heard on exhalation. Wheezing suggests that lower airways are partially obstructed with fluid or mucus. Many factors affect a person's rate of breathing. For example, breathing slows during sleep. The rate of breathing increases with fever, pain, and emotions. Drugs may increase or decrease a person's breathing rate depending on the action of the drug. A patient who has experienced trauma to the head or brain may have an abnormal breathing pattern. This occurs as the brain swells and pushes on lower structures in the brain. Other conditions in which an abnormal breathing pattern may be seen include stroke, diabetic emergencies, and toxic exposures. Observe the rise and fall of the patient's chest. Unequal chest expansion may occur when part of the lung is obstructed or collapsed because of an injury, such as a flail chest or pneumothorax. Flail chest is, by definition, 2 or more ribs broken in 2 or more places. And you'll see every time the patient inhales, they take a nice deep breath. The section that's broken apart will move the exact opposite direction. Let's see. This is referred to as free floating because it's no longer in continuity with the thorax. And this motion is actually called paradoxical chest movement, and it's a sure sign of a flail segment. When paradoxical chest movement is present, part of the chest wall moves in the opposite direction during breathing, like we said. When the patient breathes in, the flail segment is drawn inward instead of moving outward. When the patient breathes out, the flail segment moves outward instead of moving inward with the rest of the chest. Other possible causes of unequal chest expansion include pneumonia and pneumothorax, which is a collapsed lung. Well, this is the end of section 3 of respirations.